been told that they've got 30, maybe 40 minutes to allow for a good discussion. I know that's a big part of what we're interested in. I'm delighted to have Dr. Andrew Pike join us today. All of us know him, maybe not personally, but at least by reputation. So it's a wonderful opportunity for us to get to know the work that he's doing, and then see how it aligns with our interests and how we might collaborate. And we're already thinking about a collaboration over the Navigator project, which we're going to keep talking about. And Dr. Pike is also working with a couple of our residents, one of our residents this year and another staff member. So it's wonderful. So a little bit about who he is. He's the current chief of the Division of Prevention and Rehabilitation at the University Ottawa Heart Institute. He's a professor at the Faculty of Medicine. So his main portfolio, what he's largely known for, is the smoking cessation program, so cardiovascular risk prevention, smoking cessation, and exercise adoption, and so strategies to prevent or primary, secondary prevention of cardiovascular disease. He's addressed audiences in over 30 nations and is sort of the guru in the field of smoking cessation and cardiovascular prevention. One of the things that you may not actually know about him is his involvement is in the Olympic Games. So he served as a physician at 10 Olympic Games and has been the team physician for Canada's national men's basketball team since 1978. So you get to travel to all these places and be on site. That's wonderful. So he's chair of the Canadian Centre for Ethics in Sports from its inception in 2003, recipient of the International Olympic Committee Award for Sports Health and Wellbeing, and many recognitions, also named at the Order of Canada. Thank you for joining us. We look forward to hearing, Iman, is this the... So it's not always obvious how we move forward, so we're asking our speakers to stay here, and then, is it the right? That's yes. It. Okay, excellent.
Thank you very much. Thank you for that very gracious and that very gentle introduction. It's a pleasure to see some familiar faces. I won't say some older familiar faces, but it's very nice to be in this esteemed company. I learned long ago that what you should do is to hang out with smarter people. And so I'm pleased to be able to do that today, and I'm reminded that I first learned to do that in biology 031, when I used to sit next to this really bright guy by the name of Bill Hogg, who was, of course, a year or two older than I. And I must say I was very impressed as a naive young undergraduate when he made a comment one day that he wouldn't be there next week. Could I maybe take some notes for him? Because he was going to be presenting a paper at a national physics conference. This is pretty cool stuff. The rest is history. Dr. Dalva and I also have a relationship, which I won't go into any great detail, but it does involve Old Fort Henry in Kingston, Ontario, and I'll be pleased to provide you with greater details later this morning. So I thought I would take advantage of the opportunity for our conversation to very briefly just talk a little bit about some of the work that we're doing at the Heart Institute, which I think would be of mutual interest, particularly of mutual interest given that so much of it focuses on prevention. And I constantly remind my colleagues at the Heart Institute that primary prevention can prevent or postpone 33% of all deaths. That secondary prevention can prevent or postpone 23% of all deaths. And I take particular joy and express specific glee when I mention to my surgical and interventional cardiology colleagues that actually perfect care is very substantial, and that's a fact that I continue to drive home to my colleagues at the Heart Institute. I do want to introduce you this morning to several of my colleagues who've been instrumental in leading or participating in the research that I'm going to discuss very briefly today. Some of you will know Dr. Robert Reed, who has a particularly unique combination of skills in that he's an exercise physiologist who did an MBA who ultimately had a PhD in the behavioral sciences. So is particularly well versed in a number of initiatives that have developed in our midst. Sophia Papadakis is now resident in Crete, where the weather is infinitely better. She remains an adjunct professor, faculty member at the university, and has taken some of our work internationally because we're now collaborating with colleagues in the University of Crete and doing things within the European community that relate particularly to smoking cessation. And many of you who have been to Greece will know that the smoking rate in Greece is substantially higher than it is in Canada. Heather Tulloch is a clinical psychologist with an obvious focus on mental health issues and brings those particular perspectives to some of the work that we've been doing in smoking cessation, and I'll talk a little bit more about that. Jennifer Reed is an exercise physiologist who's an associate scientist with us now and who brings very specific exercise science background and orientation to some of the work that we're doing. Carrie Ann Mullen is a recent was a doctoral student and has recently received her PhD from some of the work that she's been doing with smoking cessation. And Stephanie Prince-Ware, one of our postdoc fellows, is currently doing very interesting work on sedentary behavior and sedentariness, which is, of course, a new concept. So much of what I talk about this morning will perhaps be, and I should say perhaps be because these slides were thrown together under some rather unusual circumstances, and neither you nor I have any real idea what is the next slide. So we have a lot in common. None of us know what we're going to say next. But I do want to start off by talking about some detail about the work we've been doing in smoking cessation. And one of the conditions that surrounded my appointment to my current position was that, people can ask for 45 feet of wet lab space or a CT scanner or something. I asked for a dedicated nurse who would have sole and principal responsibility for developing a smoking cessation program that could be systematized within the Heart Institute. And so much of what we've accomplished has occurred as a consequence of the leadership and the energy that Bonnie Quinlan, she's no longer in that position at the Heart Institute, but the leadership and energy that she provided to us. Really Sutton robbed banks because that's where the money was. And if you're interested in prevention from a cardiovascular perspective, the money is in smoking. It's just so obvious. This is acknowledged as the single most powerful preventive intervention that we can deliver in clinical practice. That's an acknowledgement that is more rhetorical than actually any kind of realistic commitment until recently to addressing this issue. And so it's also perhaps the most neglected of the major cardiovascular risk factors. And so it seemed to me to be a very fertile area for research to try to improve upon the fairly dismal approaches that we were taking to address smoking in the patients that we saw at the Heart Institute. And I can say that we used to have this annual existential crisis. Well, what can we do about smoking? We've got this little smoking cessation clinic, and people come and people go, and they don't show, and the staff get bummed out, and it's, a lot of wringing of hands and shrugging of shoulders and shaking of heads, until one day we sort of said, look, on floors 2, 3, and 4, we'd see 2,000 smokers a year. And what are we doing about that? We shoot residents at dawn if they fail to recognize someone who's got diminished renal function or dysglycemia or dyslipidemia or hypertension. And yet we've got this casual, serendipitous kind of I see you happen to be a smoker. Might be a good idea to stop smoking. Why don't you mention that to your family physician if you've got one, after you leave here? And so out of that came the idea that we would develop this approach which would systematize the identification, the documentation of smoking status, and that would automatically lead to an intervention likely to be of assistance. Because, of course, the leading cause of admission and readmission in the acute care setting are tobacco-related diseases. And as we struggle with yet another existential crisis, how can we possibly sustain the healthcare system in its present form, or even a markedly mutated form in the years to come? The whole issue of readmission and prevention should be rearing its head and achieving a level of prominence, and smoking cessation should figure distinctly in those kinds of discussions. So there are some challenges ahead. So out of that came this thing that we termed the Ottawa model for smoking cessation. And I can remember the day that we coined this because we were sort of saying, well, we've got a schema, and everybody, we have the Ottawa ankle rules, and there's, there are eponyms and there's this and then that. And if we want this to have some currency, if we want to be able to talk about this, we got to provide it with a name. So, we were brilliantly creative and came up with the name Ottawa model. That's how that term came about. But it's all about doing ordinary things extraordinarily well. And that's a mantra that I constantly repeat in talking about many of the things that we do. And so it presupposes that the practice system, in our case, the institutional system originally, mandates that you must identify the smoking status of your patient. It's not left to serendipity. You go to most Canadian hospitals and ask, smoking is Canada's leading cause of preventable disease, disability, and death. I'm sure you have some idea. How many of the patients admitted to your elsewhere general hospital last year were smokers? Most of them cannot tell you. Which is an outrageous kind of mission if you think about it. And so the system that we put into place mandates that you must ask a smoker, or you must ask all patients about their smoking status. And you do not ask, are you a smoker? Because to do so very often gets replies no, because people have understandably decided that they are a non-smoker 48 minutes earlier on a gurney in the emergency department. And so they misrepresent their smoking status. So you need to ask, have you used any form of tobacco in the past 6 months, or have you used any form of tobacco in the past 7 days? And only then will you get an accurate representation of the smoking status of your patients. And there have been a number of publications that have pointed out that the attributes of becoming a non-smoker have been underestimated simply because so many of those seminal studies misrepresented themselves as being non-smokers when they were not. That must then be documented. That documentation triggers a visit from a smoking cessation nurse or an intervention from a clinician about smoking cessation, makes available pharmacotherapy used on an evidence-based best practice approach. None of this fixed paradigm, gee, here's some NRT, put this on for 4 weeks, decline the dose for the next 4 weeks, and in the final 2 weeks, decline it down to the lowest possible dose. That's ancient in terms of approaches to smoking cessation. Being prepared to titrate the therapy to meet the needs of a smoker. If you've got somebody smoking 2 packs of cigarettes a day, the standard dose of a nicotine patch isn't going to come close to easing their symptoms of withdrawal and craving and allow them to acquire the repertoire of non-smoking behavior. Now, one of the big zombies that we confronted, and I don't think I have any zombie slides here, but we now talk about confronting the zombies of smoking cessation. And one of the big zombies is that we can't use NRT in cardiac patients. That's a hopelessly outdated concept. And so in many of the talks and discussions we have, we show about 16 slides in rapid succession that show you the evidence that there's absolutely no relationship between the use of nicotine replacement therapy and accentuation of cardiovascular issues in patients with underlying cardiovascular disorders. And given that we can now go out and trumpet that, look, in the Heart Institute, in the coronary care unit, within a few hours of being admitted with an unstable angina or an acute infarction, you may have 2.5 21 nicotine patches on your arm. People go, wow. And the only side effect is that we've had a reduction in the number of people signing themselves out, a dramatic decrease in the acting out behaviors that occur when people go into nicotine withdrawal, and as we will see, an accentuation in the number of people who ultimately stop smoking. And then we provide an approach that facilitates longer-term follow-up using interactive voice recognition technology. And we published the results of this kind of work in a number of settings. And then, as a consequence of some resources that were made available to us, we're able to export this particular protocol into hospitals in the Champlain region and showed that we were able to very distinctly improve the biochemically validated levels of smoking cessation once you introduce a model like this into a general hospital setting, because it must be acknowledged that smoking cessation rates are generally higher in those in cardiovascular settings. Well, here's where we started to become like the dog that caught the car, because as a consequence of the evidence of the applicability of this protocol in more hospitals, so we expanded across the country. And we're now involved in more than 300 healthcare settings across the country, hospitals all across the province. We created a center of excellence in the Maritimes, a center of excellence in British Columbia. And so Now the story becomes one of knowledge transmission, knowledge dissemination, influencing practitioner and institutional behaviors, et cetera, et cetera. What I do want to share with you is some data that some of you here this morning are familiar with, and this is work that was done by Carrie Ann Mullen for her PhD thesis, looking in 14 hospitals and comparing those who received the Ottawa model type intervention, following them for 2 years, and looking at things like patterns of healthcare utilization. And here's what we see when we deliver smoking cessation services to patients in an acute general hospital setting. In the 30 days after, there's a 50% drop in all-cause readmissions, a 45% drop in smoking-related readmissions, and a 30% decline in emergency room visits. And in the case of cardiac and respiratory patients, these are generally very expensive readmissions. So some opportunities to achieve some substantial savings. Well, you say that's short-lived. What happens? People lapse back to smoking. If you follow these individuals for 2 years, you still have a 21% overall drop in readmissions, a 21% drop in smoking-related readmissions, almost a 10% reduction in emergency room admissions, and guess what? You get a 40% decline in all-cause mortality. There is nothing that you can do in a hospital setting, even in terms of the treatment of the presenting condition in most cases, that produces data like this. And by the way, this is entirely consistent with data that's been derived in other studies that have looked at the provision of systematic approaches to smoking cessation in cardiac units and in other specialty-focused settings. So very good evidence, and the result is that you can understandably plot and predict and document a substantial reduction in healthcare costs as a consequence of that kind of intervention. And you spend $80 and you save more than $4,000, because $80 is approximately the cost of delivering these services in that hospital setting. And not surprisingly, the greatest impact is found in these particular diseases, principally respiratory, which have such a high rate of readmission in the period after discharge, but also in things like atrial fibrillation, etc. So the potential in Canada is that we could, with a $45 million investment, save $2.3 billion in terms of the healthcare costs, which are consumed as a consequence of persistent nicotine addiction. By the way, that's another concept we struggle constantly to get across. I would hope that you would commit never, ever again, in any sentence in which the word smoking appears, to use the word habit. Because to do so immediately reveals you do not understand the fundamental mechanisms which impel and maintain smoking behavior. So, with that, Carrie Ann Mullen and other distinguished individuals published most recently in Tobacco Control an analysis of this work, and there are further publications that are currently in press in that regard. Well, let's go back just a bit, because as this process began, so we began to get inquiries from our colleagues in the primary care setting about, well, if this works in hospitals, why couldn't one adapt a model to address this issue in the primary care setting? And so Sophia Papadakis, now in Greece, undertook some significant research and meta-analyses and systemic reviews and so on, and acquired a considerable experience and perspective in terms of the delivery of smoking cessation interventions in the primary care setting. And so we developed a model based on the Ottawa model, precisely for a primary care setting, and we piloted it in a number of family health teams, most of which were in the Champlain region. And what we were able to show is that we could significantly increase the number of these interventions that are sort of the hallmarks of smoking cessation practice. We could also significantly increase the number of quit attempts. We could triple the number of patients in the primary care setting who were smoke-free 6 months after the intervention was received. So, and a 30% rate of smoking cessation, biochemically validated, is a very good result. And so once again, this was all about doing ordinary things extraordinarily well. And so as a consequence of either the insight or the generosity or the largesse of the provincial government, we then were provided with resources to expand this program across the province, having demonstrated that we could change healthcare provider performance in these particular areas. By the way, many of you may be familiar with the 5 days of smoking cessation. Ask, advise, assist, we would suggest that those are outdated concepts, right? And they kind of presuppose that the only way people can stop smoking is if they, we want you to stop smoking, I want you to go away and think, and when you're prepared to make a quit attempt, come back and see me. As we don't do that in any other area of medicine. Gee, we've got evidence that you've just had an infarct, and we've done some things. We want you to go away and think about whether you're prepared to make a left ventricular afterload reduction and embark upon a platelet disaggregation strategy while minimizing the likelihood of ventricular distortion. We say, you've had an infarct. Gee, there's some things that we can do, and we're going to do this. I'm going to help you, and we're going to see how that goes. And exactly the same thing can be done in terms of smoking cessation. You're going to hear a whole lot more in months and years to come about the reduce to quit approach, which simply is, gee, I see you're smoking something. Look, I think there's some things that we can do. I'd like you to just put this patch on your arm every day. We're going to see you again for the next 3 weeks. You just carry on with your life. You can carry on. Just carry on. Come back and see us in 2 or 3 weeks' time. And inevitably, when patients return, their tobacco intake is reduced by 40, 50, or whatever percent, and then you can have a discussion about, gee, you've done really well. Look, I think if we did a full court press, we could really improve upon that. What do you think? Say we give it a go. So that's the RTQ, the reduce to quit paradigm. But we now talk about asking, advising, and acting. Physicians are very good at asking and advising. They have been less frequently involved in the action, because this paradigm, this dogma has been out there that the only people that can help stop smoking are those that have gone away and thought about it and come back and told you they're ready to stop smoking, which is a bit of an outdated concept. So Sophia and colleagues also then began to look at ways in which we could influence primary care practitioner behavior in terms of delivering these kinds of interventions, identifying the barriers, providing facilitated approaches to assist practices as well as the practitioners address these issues. And as a consequence, began to undertake some research in significant numbers of family health teams across the province, so that we could demonstrate that we were able to change professional practice in these particular settings. Well, we are now in 83 family health teams all across the province of Ontario. And that reach is very substantial when you consider that those family health teams have more than 850,000 rostered patients. They involve nearly 750 physicians, almost 280 nurse practitioners, nurses, pharmacists, and so one can configure in these family health teams approaches which are unique to and reflect the culture and the circumstances of that family health team and help them dramatically improve their smoking cessation behavior. And once again, we can show that we can increase the numbers of patients involved in those interventions. Now, we also know that 45% of all cigarettes consumed in Canada are consumed by individuals with significant psychiatric comorbidities. And there are very distinct relationships between the need and the use of nicotine and the degree to which smoking causes an alleviation or a reduction of the underlying psychiatric symptoms. That's true of depression, because most clinicians are unaware that hundreds of times a day smokers are administering small doses of monoamine oxidase inhibitors that are part and parcel of tobacco smoke. And it's particularly true of those with schizophrenia. You stimulate the alpha-7 nicotinic receptor, and you dampen the frequency, the volatility, the intensity of all of the stimuli that constantly assail an individual with schizophrenia. So trying to identify ways in which we can help this very vulnerable population has also figured prominently, and Heather Tulloch has led in research in this area as we've looked at ways in which we can assist individuals with underlying psychiatric conditions stop smoking. And this is our most recent study, which is just now in final stages of revision, and so it's not yet published, but looks at the impact of varenicline, the impact of titrated dose nicotine replacement therapy and the emergence or re-emergence of psychiatric or neuropsychiatric symptoms in those stopping smoking. And what's unique about this study is that unlike most smoking cessation studies, we did not specifically exclude those with psychiatric diagnoses. In fact, they were welcomed into the study. And I can tell you, with no risk of compromising the right to publish, that rates of smoking cessation are very similar in those with psychiatric illnesses. May require slight but those who have had a psychiatric diagnosis are, irrespective of the group in which they were in, likely to perhaps have an emergence or accentuation of some of their psychiatric features. Nonetheless, overall, the stability of their underlying psychiatric condition actually improves as a consequence of smoking cessation, and that has consistently been documented on a global basis. So I'm going to skip through this because I do want to just talk about how now we're involved in respirology clinics, now we're involved in stroke clinics, and get this. Our orthopedic surgical colleagues in the city of Ottawa now want to introduce smoking cessation in their plaster rooms and fracture clinics. So, you know, there is light at the end of the tunnel. And hopefully we can report on that in the future. But all of this is really about changing professional and institutional behavior. And the other way in which we've sought to disseminate the knowledge is that we've hosted now annually, just completed the 8th year, what is now the smoking cessation, National Smoking Cessation Conference in Canada, increasingly seen as an international conference, and several hundred come to Ottawa every year. And the focus of this conference is purely on clinical practice as it relates to smoking cessation. It is not about tobacco control and taxation policies and all of those very important other elements of tobacco control, but rather we wanted to address this from a clinical perspective to kind of redress the indifference and the neglect which has surrounded this major health issue in the past. Well, let's take a giant step sideways and just talk for a minute about some of the other issues that we're involved in. You are all aware of the degree to which atrial fibrillation, by virtue of the population aging, is becoming a much more prominent, much more prevalent issue that we must deal with. And sadly, the quality of life of those with atrial fibrillation may decline quite precipitously, and that usually occurs as a consequence of their diminished levels of physical activity, which then translate into diminished physical capacity and diminished quality of life. And so what Jennifer Reed, what we have been doing with Jennifer Reed is looking at the way in which we can influence the quality of life of those with atrial fibrillation by helping them become fitter through a variety of approaches to exercise training. And once again, and I think there's an important lesson here, before we embark on a particular research direction or entity, one of the things that we recommend that our postdocs and others do is that let's do a systematic review. Because you'll learn a whole lot about the area of interest. You'll be able to get a publication, perhaps more than that, as a consequence of that, particularly if this is an area that hasn't really been explored in any depth. And it can really guide and influence what we do next. And so what we find is that all of the guidelines for the management of atrial fibrillation are remarkably silent on the whole question of exercise training. And so we began to look at ways in which exercise training can be beneficial. And somewhat last year we published in the CMAJ one of these 5 things you should know about, and this was exercise training in patients with atrial fibrillation. But what we also wanted to do is to look at a very different way of providing that exercise training. And here's where some of our murky jock backgrounds kind of got brought to the fore, because some of you will know that high-intensity interval training is a very effective and a very efficient way to substantially improve the overall physical capacity or performance capacity of an athlete. Why wouldn't it work in individuals, in this case, with atrial fibrillation? And so this is a form of exercise in which you exercise very intensely for maybe 30 seconds, and then you have 2.5, depending upon the protocol, 3 or 4 minutes of lower intensity exercise, and then you ramp it up again. And of course, this raises a few eyebrows when you talk about doing this with cardiac patients, but that's what we've done. And here you see a typical protocol of intense relax, intense relax, intense relax. And you can do that in a variety of settings, and we're looking at this in a variety of formats. And as a consequence, again, of the work that we've done in exploring these issues, we've been able to develop a number of publications that provide what we think are very practical guidelines for practitioners about exercise and physical activity. And you know, when I talk about physical activity and exercise with many of my colleagues, they're all over, you know, subtract your age from 227, multiply by the inverse square of your area code, add your social insurance number, and subtract 27 if you were born in a leap year. And that gives you a heart rate that you should then now go and try to emulate. And, hey, it's nowhere near that complicated. And so what we're trying to do is to persuade or provide information to all of our colleagues that you can use some very simple strategies to encourage people to become physically active. Just doing some ordinary things extraordinarily well. And you do not necessarily have to include all of these kinds of elements, but just walking your most straightforward way to assess exercise intensity is the talk test. If you can still have some semblance of a conversation with somebody that you're walking with, skiing with, skating with, paddling with, and it's not, you know, what do you think about the budget and the reverse reciprocal tax reduction in institutions with corporate structures that begin with the letter X, right? It's, do you think the Senators will ever win another hockey game? That kind of conversation. Because there's, the moment that you lose the capacity to have a conversation is the point at which we term this ventilatory threshold, which parallels the lactate threshold. And it's a physiologically very sound, very practical, very straightforward guide for exercise intensity for anyone. So, you know, there's a little rubric that we would like to get out, and so we continue to publish this in a variety of settings, building on the evidence that we've got. And then in the moments that remain, and we'll try to fly through this really quickly, we've been looking at sedentariness, because the evidence continues to accrue that irrespective of how physically active you may be at certain times of the day, if you are sedentary overall throughout that day, there are substantial decrements in terms of your overall health, et cetera, et cetera. And Stephanie Prince-Ware has now become an international guru on sedentariness. And many of us have, I think this is a young Bill Hogg, I'm sure that many of us have had years of training in these kinds of activities. So the opportunities are everywhere to be able to address this. And what we are able to show is that those who have high levels of sedentariness do very badly in terms of all of the indices that we measure in terms of those who are addressing
I think you can finish your sentence. Do you go back to the previous slide? I'm really interested in seeing the opportunities to overcome this, because one of the things that has become really popular is this standing desk.
Yeah.
And so when we say, you know, there's a difference between the problem of sitting and the problem of being sedentary. And can you say a couple of words about, you know, is it, if you stand instead of sitting, is that better? Or are we talking about moving? So I'm interested to see, so these are all things where you're actually moving, you're not just standing.
Yeah, so there isn't a standing desk slide here, but the evidence about standing at work is that it is actually advantageous and beneficial. Not to a huge degree, but if you consider that you're doing that repeatedly over the days, over the weeks, over the months, then the advantages become quite significant. And, you know, I would suggest that you might find fascinating a conversation with Stephanie Prince-Ware on this, because it would provide you with additional insight into this. But it really is quite fascinating. And we sort of pat ourselves on the back, oh, you've done cardiac rehabilitation, you're now doing, and failing to recognize that if people are inert or immobile throughout significant proportions of the day, there are profound disadvantages and decrements in performance that occur. And so we're continuing to look we're using accelerometers and so on to to assess levels of spontaneous physical activity, and Stephanie and Jennifer are very prolific in terms of publishing in this area. I would, and I will say this in sort of entre nous, we are basically 4 researchers with some postdocs. And I would argue, punch way above our weight in terms of the research enterprise at the Heart Institute, and actually have been successful in equaling and in some cases exceeding the intake of grant support for research in our particular area, in contrast to the activities of some of our colleagues in other areas, which comes as a big surprise to the officials in the Heart Institute, but it's always great to be able to say that we are doing so. Finally, I just want to talk very briefly about a new area of interest, and this is women and heart disease, and we have created at the Heart Institute the Canadian Centre for Women's Heart Health, and in a few weeks' time, and I think it's really important I draw your attention to this, we're having a national summit on women's heart health, and the great and the good from around the globe are coming to present at this. And I would suspect this would be of profound interest to primary care practitioners. And I'm going to turn this into a naked commercial message, because I would love to be able, particularly for those of our colleagues in the Ottawa area, to advise them about this, because it occurs to me that that's probably not been advertised in the kind of using the vehicles that typically are read. So I may come back to you about this. And so because cardiovascular disease is the leading cause of death amongst Canadian women. It is not breast cancer. And so there's a great public level of public misinformation that has to be addressed. And one of the things that we did was early on carry out the first and only ever national survey of Canadian women regarding their knowledge and behaviors and appreciation of risk of heart disease. And the results were absolutely impressive. The number of women who self-identified that they were highly knowledgeable in this issue, who were unable to address or identify symptoms or risk factors for heart disease, was startling, absolutely startling. Now, we have also just completed a national survey of healthcare professionals, which is now being prepared for publication. And it is equally startling. The dated concept of heart disease is a disease of middle-aged men, et cetera, which I think all of us thought had receded into the past. The fact that we can identify women at particular risk of subsequent cardiovascular events during pregnancy is a reality that's known to all of us, but we don't have systems in place or a sensitivity to or a receptiveness to addressing, to following up on those who are identified in an appropriate way to forestall the CVAs and the MIs, which are inevitably going to befall those individuals as a consequence of their increased risk. So good work beginning to unfold in that particular area. And then just to finish very rapidly, one of the things that we ventured into is the whole area of popular education or public education, using an approach which involved the Ottawa community and a phantom community elsewhere in the province of Ontario, providing education, multimedia, television, et cetera, information designed to sensitize 35 to 50-year-olds about the importance of sodium intake in their diet and compare and contrast what happens in those particular communities. So, we've been trying to operate in terms of our research activities in terms of the primary prevention, the secondary prevention, and the primordial prevention or the population health kind of approaches. Now, here we had some very innovative approaches. You may remember these Give Your Health Head a Shake television commercials. Unfortunately, I think one of the reasons why this didn't proceed in the way that we had hoped for is that Ottawa is kind of cardiovascular Shangri-La. And ours is a city, at least certain elements of the city, of white-collar civil servants, high-tech, run along the canal, cross-country skiing in the winter, health-conscious, upper-middle-class individuals. And that's a challenge, and I think one of the lessons we've learned there is that we should probably do these kind of studies in other settings where the opportunity to identify change would be more stark. We did find high levels of knowledge, But on the other hand, while people were aware of this, they didn't really see this as being their personal problem, and most were not able to commonly identify high sodium content foods. And while people expressed concern about this, in fact, their eating behaviors didn't reflect the concern that they articulated. So more work ongoing in this particular area, and a very sophisticated kind of investigational construct with some intriguing lessons learned. So I'm going to stop there because I realize I've really gone over a lot of time. And I hope this is giving you a little bit of a flavor of some of the work that we're doing. We've got Nordic walking studies. We've got something that I realized I should have included today is a study looking at how we can help primary care practitioners influence health behaviors of their patients. And the takeaway message from that, and we've published about this, is that it's all about integrating with community resources and being aware of the resources in your community and guiding and engaging your patients to become involved with those agencies, organizations, and settings. It is not going to happen simply on the basis of an admonition or an instruction or advice in the clinic setting that, gee, you need to exercise more often. That would be a good thing for you to do. So I think the advent of the family health team and the kind of opportunities that exist within those constructs to really develop integrated approaches with these kinds of facilities in the communities affords us some opportunities to make some substantial gains in that respect. But I want to apologize for going over time. I want to apologize for speaking so quickly. I want to apologize for the omissions that were occurred as a consequence of the rapid way in which these slides were assembled. And I welcome your comments, your questions. Thank you.
And let us know if there's somebody online.
Thanks very much. And one of the things that I listened to the CBC when you had your conference in January and the debate, which was interesting about healthcare workers and smoking. And I work in a family health team where we have a full-size picture of the smoking cessation nurse at the front door, who then we refer to, and is quite successful. However, every day I go into that hospital, there's smokers standing at the back door. And I was working with our family health team over at the Ottawa Hospital, and we were having a discussion about the smokers in the parking lot. And I made a comment, so what resources are available in your hospital to help your workers quit smoking? And it was interesting because I said, well, what about occupational health? And they said, well, that's not their job. I said, but you have a resource here in the family health team who are people who do this every day. My question to you is, have you tried to tackle that hard nut to crack?
Absolutely, and I think we also constantly bewail the fact that we are not doing enough to help our colleagues, although very limited number of colleagues now, I mean across disciplines, who are smokers, but we're not doing enough to help workers in the healthcare setting who are smokers. And the data here is quite disconcerting because there's this whole concept of presenteeism, and I don't know whether you're familiar with that concept, but presenteeism is the time that you spend at work not actually working. And the amount of presenteeism that is manifest by smokers is enormous. And so in the hospital setting, you've got, well, it's my break, I'm going to go down and have a cigarette, and oh, geez, I can't, God, I just can't take the CCU for a moment longer. Can you just cover my patient while I go out and have a, et cetera, et cetera, et cetera. And so hospitals themselves are becoming aware of this. I would say that I think the best example of where we've been able to engineer or achieve this is in our hospital system in New Brunswick. And their occupational health unit is all over this now. And they've done this in a very imaginative, very sensitive, and strategic kind of way with considerable success. I think one of the challenges is that by and large, occupational health units are not held generally in very high esteem by members of the workforce in many healthcare settings. And I say that with absolutely no disrespect intended. And so they're not seen as the place that you would go to have these kinds of issues addressed. And so I think there's some work to be done to address that. Certainly, we constantly are have tried to stimulate interest in that area, and I guess we've been a little bit delinquent in that we haven't been more persistent, but I think that is absolutely an area. And notwithstanding the debate and the result of the debate at the conference, I think this is a process that is going to be ongoing. It does not seem to me to be in any way problematic for a hospital or a health organization to say, as of January the 1st, 2018, we will no longer be hiring smokers. And what you basically do is you evolve in that kind of way.
Get a constitutional.
Cancer Society, Heart and Stroke Foundation have been doing this for years.
Really?
Yeah. And you know, so immediately the question always comes is, oh, you can't do that, it contravenes. Well, am I compelled to hire a nurse to work in my smoking cessation clinic who's a smoker? Clearly not. Why do I feel that I would be compelled to hire somebody to work in a healthcare setting? We hear all the time from our patients, my God, I'm trying to stop smoking, I'm doing okay, but when that nurse comes back from her break and breathes all over me, it's torture. Right? So we've kind of lost sight of and strategically introduce those kind of concepts. At the same time, trying to do more to help our colleagues in healthcare settings who are smokers, who already feel embarrassed and about this. And you know, I spoke to the first year medical class on Tuesday this week. We do 2 hours of smoking cessation and advocacy on tobacco control mixed in. And what's really gratifying, you've got a room full of 130 or whatever it is, medical students, and you ask, how many of you have ever smoked? Not one single hand goes up. No, but now, you know, and there was a challenge for us because most clinicians, most younger contemporary clinicians, have no idea how difficult it is to stop smoking. And it's been said that unless you've been a smoker, you're not likely in your life to ever have to undertake the monumental personal transformation that's necessary to become a non-smoker. This is one hellaciously powerful addiction. You know, we get exercise about intravenous drug use, and we conveniently forget that smoking is intra-arterial drug use. Because the moment we take a hit of tobacco smoke, it's going wham in your left ventricle, etc. Starting, I'll stop.
I just wanted to facilitate that discussion.
So it just sounds like what you're saying is you're challenging that this is a sort of a health behavior that falls along the behavior change theory. Is that what you're advocating? And so if that is can that be applied to other health practices, or is it unique to smoking? So can you apply this approach to physical activity, for example, or what's your sort of theoretical understanding?
So completely out of the blue, the clouds parted a couple of years ago. And we got this missive from the Ministry of Health saying, here's money. We want you to create an auto model for undiagnosed diabetes. Well, we don't know anything about diabetes. Yeah, but you guys know how to do this in a systematic kind of way. And so we've now been carrying on the study, the OMRUD study, the auto model and undiagnosed diabetes. So I think that the template of doing things systematically, not leaving things to chance. I mean, we've all recognized, I think, the importance of those protocols. But now we have a way with electronic medical records and so on. We can really systematize these approaches in a variety of practice settings. And so those kind of principles are applicable. Absolutely.
So I have a question which maybe ties into this. I think your closing statement was, we can't underestimate the importance of existing community resources in supporting the primary care physician patients in achieving lifestyle changes. So we briefly spoke about the Navigator study, which we've undertaken. We're just about to roll it out in the next few months. And so I'm interested in your experience with the community resources, because one of the things that we want to make sure is that we don't promote the use of a community resource that hasn't been that effective or culturally appropriate, or that where there's no capacity to take on more. So what has been your experience with the community resources? And have you in any way sort of systematically identified and prioritized?
Yeah, so great question, and thank you. So one of the challenges that we face is that people come in and participate in the cardiac rehabilitation program, and they, so they undergo this kind of near conversion experience for 2 or 3 months, and they're now 18 months later, they're back doing whatever. Right? And so we identified that one of the challenges there is the lack of community resources, community programs, and so on. So we developed this thing which we now call Heart-Wise Exercise. And so we now work with community organizations, community facilities, YMCAs, community recreation centers, etc. And we sort of say, we will give you the Good Housekeeping seal of approval, the Heart-Wise Exercise thing. If you fulfill certain criteria, and this will allow you to identify yourself to the public as a place that is, right? So we're now in 369 settings across the province of Ontario, and I think 100 and something of those are in Toronto. It's always great to be able to go to Toronto to tell them how to do things. Right? So that's kind of a model that we use, and what it means is that you do have to do due diligence to identify what's there. We developed a program up the valley called Get With It, and the WITH is the acronym for Walk in the Halls. And so you've got small communities that don't have necessarily, but there's a school. And you open the school at night, and there are corridors, and people can walk in the schools, and you can create a community walking program.
That's wonderful. We'll have to connect about those resources, and that's wonderful.
Yeah, so I think it's wonderful. I think one of the challenges is dissemination of the awareness about even not only the resources, but for example, your Health-Wise seal, because I work half a block down the road from you at the Civic Family Health Team, and I wasn't aware of this. We have our own sort of Healthy You program, which is not only for cardiac patients, but we're a family health team, so we have resources that a lot of the practitioners on the outside don't have. So I think from the LHIN's perspective, it would be nice to kind of have some kind of amazing directory of resources that would be really pushed to the practitioners, just like there's a parent resource center that has a huge directory of resources for parenting. Sort of thinking on a broader level, something like that, where you kind of go, okay, cardiac exercise, and then you find what's in your neighborhood.
What we did,
because that's a challenge. That's really difficult.
We produced for the primary care community in the Champlain LHIN a Champlain-specific guideline for the management of modifiable cardiovascular risk factors, identifying all of the community resources that were